Good morning. I thank the organizers for inviting me to speak at this conference. I hope English is okay. I'll try to speak slowly, please. Okay. So, we live today in a time where everybody worships eternal youth, physical perfection. If you please don't take pictures of the clinical pictures. Can you tell them in Ukraine not to take pictures? And I did go. They understand. Okay. So in a time where physical youth is worshipped and where an eternal youth is, we deny aging and death. In this context, to have an oncological wound, a fungating wound, is really devastating. The definition, of course, fungating wound is a difficult terminology. In Italian, we have no word to describe it, really. We call it neoplastic wound or oncological wound. And the definition fungating comes because of the shape of being like a fungus, but we see many, many different wounds that do not fit in this terminology. You can have fistulas and craters. There are roughly 3 to 4 types of wounds in this classification of fungating oncological wounds. One derived from primary skin tumors, so like malignant melanoma that develops into a fungating wound. One from the developing from secondary infiltration of local tumor. And the other one, due to treatment or combined treatment, can be surgery, radiotherapy, or chemotherapy. The fourth kind that we can add here are chronic wounds that actually are for many, many years, and they metastasize and become a tumor like Marjolin's ulcer. This is an example of a malignant melanoma that became a fungating wound. Another primary skin tumor. If the lights are too hard, I know, maybe a little bit darker, you can see better. And this is from a mastectomy. That's a typical fungating wound. This is caused by radiotherapy. I don't know if you can see properly. Thank you. Yeah, if you put down the lights a little bit. This is both of them. This is a sarcoma on the other side, on the groin, and we had radiotherapy. It's like a second-degree burn, and this as well is due to radiotherapy. And normally it happens before they finish the treatment, so it's very important to treat them properly so they can finish radiotherapy. This other type is after adenocarcinoma and surgery, and you can have complications like retracted fistula, and you can't even apply a pouch, a colostomy here. If you look at the epidemiology, there is really no studies done across Europe or the world. There are regional studies. There was a study done in Switzerland, one in the UK in the 90s, one in Australia, one in the US. But if you look across all the studies, you can assume that between 5 to 10% of all cancer patients will develop a fungating wound. If you look at other epidemiological studies, they predict that death due to cancer will increase by 70% within 2035, which means that proportionally also the fungating wounds will increase. The most frequent site of the fungating wound is breast, followed by head and neck. We don't know why some patients with cancer develop a malignant fungating wounds and others do not. There are two, we assume, the hypothesis that maybe they represent the end stage of cancer, or they are representing rapidly progressive cancer, but not all fungating wounds fit in this definition. Obviously, once chemotherapy and radiotherapy do not work anymore, the wounds are progressively worse. So at the end stage of illness, they become worse. There's no age limit. It's not true that only adults develop a fungating wounds. Children also can develop it, but proportionally, children with cancer are fewer. So also these kind of wounds are proportionally fewer in children. Some patients develop it immediately at they've been diagnosed because of the wound that they have cancer. Others can happen 10, 15 years after they had the cancer. So this is a patient that I've seen about 20 years ago in Institut Curie in Paris. And I was asked how to treat it because you could smell the wound way before you entered the room. The whole department smelled. And they used already metronidazole flagyl. After 7-10 days, frequently this patient stops working, and you cannot just continue to give them topical or systemic antibiotics. So we had to be very creative how to treat it, because 20 years ago, there were no many products with antimicrobial slow release. So you could use antiseptic, but after 10 minutes, it's not good. So you needed a long-term antimicrobial. At that time, we didn't have, so we were very creative to treat her. But I came home, and I couldn't sleep at night. I already worked for 16 years in a hospital, and it really touched me. I could not imagine what it felt to have terminal cancer and such a horrible wound. You could have, and so I decided to do my PhD on these patients. I've decided to do my PhD on them, and I did a study that's phenomenological. It's the cousin of medical anthropology. So what I wanted to look at really is what it felt, the patient experience of having a wound like this and terminal cancer. So when I asked the patients, so is it terrible to have a fungating wound? And they say, I see the upheaval. It's all to do with having cancer. You know, terminal cancer, that is a big deal. Other than having a fungating wound, that is an extra. She was 42 years old. For this study, I interviewed two groups of patients, one in Italy, in Florence, with an oncology department, and one in a hospice in London. I did my studies in London, so that's why. Okay, so what came in this research, I will not have time today to show the research I've done, because I want to speak about management of these wounds, but I'll try, when I speak about management, to also show the perspective of the patient. And 4 things came out. One, how the journey, what happened to the patient from the moment they realized they have something not going on, okay, and how they experience it. How they manage the symptoms of this wound, like smell, infection, exudate, and what were the differences culturally between the English and the Italian patients. Also, I did look at how the dressings and nursing services. So, first of all, we have to understand that oncological wounds are chronic. They can take years. So patients don't know when they have this wound that it is chronic. They discovered it along the way. And when they discovered it, they say to me, it's going on and on and on. And they said, is there something not working out? Now, if you fall down and you have a wound, we normally know it gets smaller and it closes, it heals. A wound that it gets bigger and does not heal, really, that's abnormal. So the patient don't understand what is happening. Something is not going on. And when they see that it heals in one place, but it keeps open in other places, they say, it's soul destroying. It's soul destroying. Here we go again. So there is something very unpredictable for the patient about the wound. He cannot relax because he never knows if it's going to be better or worse. Okay. This is a situation. One of the patients I interviewed in Italy, he was a doctor, and he had a metastasis due to a malignant melanoma. And he says, this is to show you how these wounds dominate patient's life. Even if they are small, even small lesions, little disturbances, I become alarmed immediately. I always think that, for example, a little skin problem is the expression of the disease that is getting worse. You know, with the appearance of the cutaneous metastasis, I'm dominated by the presence of this disease, you know, so I continually check my body because he's afraid. So he says two things here. One, really, that he's afraid, anxiety, and the other thing, he never speaks about the word death. In the whole interview of hour and a half, he didn't speak death. So what we see here, that the wounds are different from any other wound you see because it represents death. There is a link, connection with death. But also when they improve, patients are very hopeful that their cancer may be better. There is one more hope when they see the wound is improving. So pathophysiology, if you look at the books, they will tell you they start discrete, tender nodules, color changes in the skin, and of course the cell grow and divide, and the nodules enlarge and multiply. But if you ask the patients how it appears, they say at the beginning it was last November. It was just an ordinary heat rash under the shoulder axilla. I just put some Canesten on it and some powder to dry it up, and then it was fine. But then it flared up after a while. Another patient says it starts off very slight, very small area, and that area gets bigger and bigger. So what are the problems in managing for nurses that manage or doctors manage these wounds? So first of all, there are problems related to the wound, physical problem like exudate, smell, hemorrhage, infection, pain. There are then psychological and social problems of an incredible magnitude that eventually lead to isolation and depression. So when we treat these wounds, first, of course, it comes without saying we need to treat the cause, the cancer. Sometimes it means combined treatment, surgery and chemotherapy, or surgery and radiotherapy. Sometimes less conventional therapies. And when we look at the wound management, the few aspects we have to assess. How is the wound, etiology, history, location, wound bed, size, type of wound, functional limitation, very important. And then we look at the patient here, because we look at both risk factor and patient satisfaction. What are patients' preference? For example, we ask the patient, what is the thing that most disturb you? Sometimes can be leakage, exudate, sometimes can be smell, sometimes hemorrhage, and we try to give this priority in treatment. Then, of course, we have to take care of risk for infection and of bleeding and pain. And we assess the results not in terms of improvement or healing, but patient satisfaction and quality of life. So when we look at management of smell, some patients say that the wound doesn't bother them, cancer, they just can't bear the smell. They won't see their parents, children, grandchildren because they're embarrassed. So what can we do for the smell? Of course, there are many things, which means that none of them really work well. There's metronidazole, there are dressing with charcoal, there's shaving foam. Some people even did a study on the box that cats go, cat litter, deodorants, aromatherapy, incense. And if you see such a big list, it means nothing works really. But please don't forget, when you have such a bad smell, you have anaerobic, anaerobic bacteria, and topical antimicrobial, treated like infection, really may take away part of the smell, and also to clean and change dressing more frequently. So this is a patient exudate. Exudate is a big deal. So how do you take care of exudate? Why do I say that? It's so trivial. You do such complex surgery. Really, I'm coming to talk to you about how to... But the problem is that our body is not like a table. Very difficult to apply dressings, that after you turn and you go home, the dressing is not fallen or gone up. Very difficult to have enough absorbing dressing. So there is a managerial problem here. So patients are very concerned that the dressing absorber, and it's not going to be everywhere in the bed, in the dressing, leak everywhere. And if you have less dressing change, they perceive it as increase in quality of care. And let me tell you one thing, please, gauze dressing are not suitable for these wounds. I tell you because in the study that's done in Switzerland, in the study I did in Italy and UK, they use gauze. They're very painful. There are better dressings for these wounds. So we have to change more frequently if there's more exudate. Sometimes we need to put a colostomy patch if the mount is too big. But fixation is also a problem. So often the patients have a damaged skin and you cannot use anything adhesive. So you have to do a tubigrip fixation with a non-adhesive dressing. So how do you dress something like this? You agree with me that is really a challenge, okay? So this is Isabel from Institute Curie, that's her case. That's what she did. She cut a foam dressing like this, applied like this, and fix it in place with a bra. So you have to be very creative. It's trial and error to manage the wounds. So this is another case of radiotherapy. So that here they fix it with adhesive. So the patients really don't want to see the wound. So being able to have a dressing that covers the wound and they don't have to see it all the time is very important. Maybe they're less afraid that it will make the clothes dirty. They can go and have a coffee. Okay? If you have infection, there are so many antimicrobial, iodosorb, iodoflex, Acticort, Aquacel. There are many products now in the market that when I started, they didn't exist. So really we need to use them if we have bad smell and exudate. Because exudate and smell, we need to treat the cause and then they improve. Okay. Now, the literature about these kind of wounds say that the worst symptom of the wounds is smell. But a professor from Canada, Vincent Maida, He said pain, and I, in my research, also found out pain was the worst symptom. So when actually, when patients have a very intense pain, and pain can be from the tumor or from the dressing, they actually don't care anymore about dying. They wish they would die. They're so afraid of the pain. One patient, for her, had such pain from 5 years of treatment of dressing with gauze. When she would see the nurse coming in, she would start crying. Okay, so of course, the topical opioids, we can clean the wounds. We have to make sure, of course, that we give good analgesic before dressing changes if this is the cause of the pain. And I assure you, in Italy, there's literature describes that patients are not managed well with pain. We are afraid to give enough pain medication. This came out in my research, but I want to look at the literature. It's apparently a theme. Maybe now it's improving a little bit. Medical cannabis. So one of the things that happen with these patients, because sometimes we, doctors and nurses, cannot treat enough for them to feel good, they go and start to use alternative medicine, complementary alternative medicine called CAM, which there is a lot of literature for it. Some of it really has scientific evidence, like mindfulness, meditation. And now there is a research coming out on medical cannabis for fungating wounds. What they do, they use oil, they use drops of oil on the wound. And what Professor Maida, he does a lot of research on it, said that he actually not only takes away the pain, but he found out that it improves also the wound status. Other kind of alternative medicine come, you have meditation, like mindfulness has really scientific evidence. They even looked at the brain, how it affects it, so that's very useful. Acupuncture for symptom management like pain, and cannabis, medical cannabis. Of course, there is many others. By the way, 1 out of 4 patients uses one of the alternative medicine. So we have to know, because some of the herbal medicine is contraindicated with the chemotherapy drug. So it's important to ask patients. Okay, so we deal here with a body that is changing. So what happens to the patient when the body changes? So one patient says, I want to undress myself. I look at myself, I said, is this me? They don't recognize the part that becomes so disfigured. Another patient that had a tumor size of a football on the sacrum said, oh, the good thing is that I don't have to look at it. And then because it's upsetting, it's sick. And then she said, the poor nurses get to look. She feels sorry for the nurses that have to see it. A patient that had on the sacrum is happy she cannot see it, but a patient that had it on the breast, she feels every day she has to undress herself, she has to see it. So they say, this part, the sick, is not me. So they feel it's not part of their body. And there is a confusion. You know, our skin holds what is inside, and keeps us outside. But when you have a big wound and you don't have the skin, this doesn't happen. There is a confusion. Patients don't understand. It's not clear if the wound is outside or inside the body. And there is a loss of the boundaries, normal boundaries of the body. And eventually, He says, because I used to think it's all outside my body. Why can't they cut it off? But then the bit that's inside will keep growing, because I was thinking it is already an open wound, so you could just slice it up off. Another patient said, the wound is there and I'm behind it. It's not me with the wound. Is the wound outside or inside the body? So there is a confusion. Why is it important? It's important because when you use dressings, you actually establish again the normal boundaries, because the dressing keeps what inside and what's outside, if they work properly, of course. So there are different ways to deal with dressings, of course. When they don't help, you have to add more, because sometimes they don't. Often, after a few hours, the dressing can sleep, so we slide away. So it's very important to do a proper dressing. Not all nurses are equally okay technically, or equally good technically. But when the dressing is done properly, there's a feeling of cleanliness. The patient feels much better. Okay. The words patients use to describe this kind of wound, they say it's a dirty disease, it's grotesque, it's repulsive. So in this sense, to be able to clean and do proper dressing change, it really helps patient feeling clean. Just one word, don't misunderstand that we are human, and we are also affected by these wounds. Patient, family that takes care of this patient, they say they cannot take the image out of their head, and we, nurses and doctors, are not always comfortable with death or such big disfigurement or be testimony to so much suffering. This is just a case study of radiotherapy. How would you treat it? They used a hydrogel and covered with a non-adhesive or low-adherent dressing for 15 days. This is after 1 week, 2 weeks. So hydrogel is the best. Hydrogel or goes impregnated in gel. You have intersigel conformable, nude gel, and so on. And the best dressing for radiotherapy wounds. Really cool, takes the pain away, it heals really nicely. This is an article, I'm a co-author, about the challenges of a really difficult stoma management with negative pressure therapy. It was published in Journal of Wound Care. I have electronic copies I can send you if you want to see. But this is the retracted fistula and all the tricks that needed to be done in order to be able to close it. In summary, these fungating wounds are devastating, are really uncontrollable, but I can tell you that in the literature, across the literature, there is one thing very clear, the need of special care. Wound care specialists need to take care of them because they know more about how to treat them, and we need to educate. They lack education to know how to manage it at home. Okay. Thank you for your attention. Any questions?